All right, now we're going to be doing our chest and lung exam. So I'm going to start by inspecting my patient anteriorly, posteriorly, and laterally. I am looking, his shape is appropriate. His chest is symmetrical. The rate is about 16 breaths per minute, and the rhythm is equal. I see no breaths of apnea. His AP diameter, he is twice as wide as he is deep. I see no accessory muscle use, and I see no retractions. I am now going to palpate. I feel no lesions. Do you have any tenderness upon palpation?
No.
No. Good. Now I'm going to have you turn to your back. We are going to do tactile firmitus. So I'm going to have you say 99.
99.
Good. 99.
99.
Good. Again.
99.
Good.
99.
Good. I feel equal vibrations bilaterally on this patient. I am now going to do the chest or the thoracic expansion exam. So I'm going to have you take a deep breath in. Good. And exhale. I see my thumbs moving symmetrically on this patient. I am now going to percuss posteriorly and laterally, starting at the top and doing a Greek key pattern. And I hear resonance. I do not hear any dullness or any hyperresonance, which could be a sign of consolidation. Now I am going to percuss on the lateral side, so I'll just have you hold your arms up. Good. Percussing laterally. I hear resonance on that side. And resonance on that side. Good. Now I'm going to do a test called the diaphragmatic exertion. So I'm going to have you take a deep breath and hold it. Good. And I'm going to percuss till I hear from resonance to dull bilaterally. There it is. Okay, you can let it out. Good. And now I'm going to have you take a deep breath, let it out, and hold it at the bottom. And then going to percuss till it sounds dull. Good, and mark that spot. It is about, okay, you can let it out. It is about a 3 centimeter gap on this patient. I am now going to auscultate anteriorly, posteriorly, and laterally. So I'll start posterior. Just have you take a deep breath in and exhale through your mouth. Good. And again. Good. Again. Good. Good. And I will listen laterally now. So inhale and exhale through your mouth. Awesome. Inhale and exhale through your mouth. Good. And then I can have you turn around and I will listen anteriorly. So big inhale and exhale through your mouth. Good. Big inhale and exhale through your mouth. Good. Good. Awesome. So it sounds like air is moving very fluently through his, all of his lungs. I hear no adventitious breath sounds, wheezing, crackles, rails, anything like that. I'm going to have you turn around again for me. If I were to have expected consolidation with my percussion, I could have done the bronchophony test, and that is when I Have the patient say 99.
99.
Good.
99.
Good.
99.
Good. And again?
99.
And I do not hear it through my stethoscope, which means he does not have consolidation. Now the egophony test, you will say E when I place my stethoscope.
E.
Good. And again?
E.
And I do not hear him through my stethoscope. And finally, the whisper pectoriloquy exam, and I will have you whisper 1, 2, 3.
1, 2, 3.
And I do not hear him at all.
1, 2, 3.
Good. I do not hear him at all through my stethoscope. So that concludes my lung and chest exam. We're going to move to cardiovascular, so I'll have you come lay over here on the bed. Good. So I'm going to start by talking about the 5 points of cardiac assessment. So we start in the aortic valve, which is the right side. Second intercostal space on the sternal border. Then we move to the pulmonic valve, which is the left side, second intercostal space, sternal border. Erb's point, which is the third intercostal space, midclavicular line. The tricuspid valve, which is the fourth intercostal space, sternal border. And then finally, the mitral valve, which is midclavicular line, fifth intercostal space. I'm going to just inspect his pericardium for any palpable heaves or thrills. I do not see any, and he looks appropriate. I am now going to palpate. I feel no heaves or thrills. I'm going to palpate the point of maximal impulse, which is this fifth intercostal space midclavicular line. It is bounding and 2+. I am now going to auscultate with my diaphragm and the bell, starting at the aortic valve, where S2 is greater than S1, and at the pulmonic valve, where I hear S2 greater than S1, Erb's point, where I hear S2 equal to S1, the tricuspid valve, where S1 is greater than S2, and finally the point of maximal impulse, the mitral valve, where I hear S1 is the greatest. I am now going to listen with the bell at all 5 of these points. And I hear no extra heart sounds and no murmurs. Upon auscultation of this patient. Good. I am now going to have you lay, we're going to kind of roll to our left side so that I can auscultate. I want to auscultate with the bell. This moves the mitral valve closest to the chest wall so that I can hear, and you can lay back, any diastolic heart murmurs. It would help me hear S3 or S4 louder. I did not hear this with this patient. I heard no mitral valve regurgitation or anything like that. We can also have you sit straight up, and if I auscultate in this position, all 5 points, it will help me with the diaphragm. It will help me to hear any aortic regurgitation or any pericardial rubs. And I do not hear any of this on this patient. Good, you can lay back for me. So I did not hear any extra heart sounds, but if I were to hear extra heart sounds, you could hear an S3 or an S4. An S3 is considered a ventricular gallop, and that is when the ventricles are over full, and that would be heard obviously after S2. And then S4 would be after S3, and that would be if the patient had severe hypertension or stiffening of the ventricles. S1 represents the closing of the mitral and the tricuspid valve. S2 represents the closing of the aortic and the pulmonic valve. A systolic murmur would be heard in between S1 and S2, and then a diastolic murmur, you would hear that in between, you'd hear that after S2 and right before S1, and I did not hear any of this on this patient. We can also have something called splitting of heart sounds, and that is when the patient's S2 splits into two sounds, and this can be heard on inspiration, and it's when the pulmonic valve and the aortic valve close at just a little bit different times. This can be a normal finding during inspiration. However, if you hear this on inspiration and expiration, it can be an abnormal finding, and it can mean some sort of atrial valve defect. And now I will inspect and auscultate and palpate the carotid arteries. So upon inspection, I cannot see any visible pulsation of this patient's carotid arteries. I will now palpate them one at a time. This side, it is bounding and 2+. And then the other side, I'm palpating and it is bounding and 2+. It feels great. I'm now going to auscultate for any bruits. I hear no bruits or extra sounds on that side. Good. And no bruits on that side. Finally, I am going to palpate pulses. So I'm going to do the radial pulses. I'm checking them bilaterally, and they are bounding and 2+. Good, they feel great. The brachial pulses, doing them bilaterally, they are bounding in 2+. I'm moving down to the dorsalis pulses on the tops of his feet here, checking them bilaterally. They are bounding in 2+. Now the posterior tibial pulses, I feel those. They are bounding in 2+. And finally, his popliteal pulses. So I'll have you bend your knees here, just palpating that, and they are bounding in 2+. And this concludes my cardiovascular and lung assessment.